Hilton Surabaya. These are the hotel emergency procedures. In the event of an emergency, the evacuation message and alarm will be heard, informing you to evacuate the building. Please follow the green fire exit signs and make your way to the lobby entrance. This is the emergency assembly area for the hotel. There is no maintenance or testing taking place today, so if any evacuation message is heard, please respond by evacuating the meeting room. If anyone requires medical attention, DoubleTree by Hilton Surabaya provide in-house clinic and has trained first aiders who will provide emergency medical assistance. Please inform one of our hotel staff for any assistance that you may require. The hotel emergency phone number is 5555. Thank you.
Thank you for Dr. Please silakan. And also what Dr. Guiding could do with us today. Thank you to share their knowledge and experiences. Baik, Bapak Ibu Dokter dan juga tamu undangan sekalian, harapannya diselenggarakan acara ini tentunya selain menambah ilmu pengetahuan dan juga wawasan untuk kita semua, juga sekaligus menjadi kesempatan untuk menjalin hubungan yang lebih akrab satu dengan yang lain. Baik, untuk mengawali rangkaian acara pada pagi hari ini, kita akan mendengarkan kata sambutan dari Dr. Muhammad Nurdin Zuhri, spesialis mata FICS, selaku perwakilan dari Perdami Cabang Jawa Timur. Untuk Dr. Nurdin, waktu dan tempat kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera untuk kita semua. Saya mulai dari patu dulu biar kita semangat ya, khasnya Surabaya. Nanti pohon capaknya ya. Belum mulai, cakep. Pagi cerah di kota pahlawan. Langit biru, udara bersih berawan. Mari kita buka pertemuan menimba ilmu untuk masa depan.
Cakep.
seluruh narasumber dan instruktur baik dari dalam maupun dari luar negeri, para senior sejawat, panitia, sponsor, serta seluruh peserta yang saya banggakan. To our distinguished international guests, welcome to Surabaya. It's an honor to host you in our beautiful city. Kalau saya lihat tamu-tamu yang hadir pada pagi hari ini, rasanya seperti mini PIT ya. Karena PIT nanti di Bandung, tapi saya lihat sebagian peserta pembicara sudah hadir di Surabaya. Ya. Sebagai tuan rumah, saya bangga. Nah, terima kasih sudah memilih Surabaya sebagai event refraktif weekend pada pagi hari ini. Selamat datang bagi teman sejawat yang baru pertama kali ke Surabaya. Silakan, tidak hanya ilmu saja yang didapat hari ini, tapi juga silakan menikmati keramat-tamahan Surabaya. Bukan hanya orang-orang saja yang ramah, tapi juga wisata kulinernya juga ramah. Ya, banyak sekali wisata kuliner yang teman-teman sejawat bisa nikmati di sini. Di sebelah ada Tunjungan Plaza, ya, salah satu mall terbesar di Indonesia. Banyak jokes yang ada di situ. Jadi kalau masuk dari TP1 nggak tahu keluarnya di mana, bisa di TP5 atau di TP6. Kalau pertama kali ke TP bawa mobil, hati-hati karena nanti keluarnya bisa kesasar. Gitu. Ya, dilihat tema pada pagi hari ini, saya lihat dari daftar acaranya, maka ini adalah nanti akan merupakan sebuah standar baru dalam era pelayanan refraktif dan refraktif sejaring. Harapan saya adalah ketika kita mendapatkan ilmu yang bermanfaat pada pagi hari ini, kita akan aplikasikan kepada masyarakat, kepada pasien-pasien kita, dan tentunya nanti standar kehidupan dan kualitas kehidupan pasien-pasien kita akan lebih baik, dan tentunya nanti membawa Indonesia ke arah yang lebih baik lagi. Terima kasih kepada Optik Tunggal yang sudah menyelenggarakan acara pada pagi hari ini. Kemudian tidak berpanjang lebar lagi, silakan menikmati acara pada pagi hari ini. Kalau dibuka dengan pantun, saya tutup dengan pantun lagi.
Mantap, Pak. Silakan.
Suramadu kokoh di atas lautan.
Cakep.
Monumen kapal selam jadi kebanggaan.
Cakep.
Mari ikuti sesi dengan penuh perhatian agar pulang membawa banyak pengetahuan.
Cakep.
Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Terima kasih.
Terima kasih sekali lagi untuk Dr. Muhammad Nurdin Zuhri, spesialis mata FIJS. Ini saya boleh ikut bangga ya, dok ya, karena Surabaya punya dokter yang multi talenta. Tidak hanya handal dalam pekerjaan atau bidang kedokteran, tapi juga handal bikin kartun, Bapak Ibu dokter sekalian. Luar biasa. Baik, selanjutnya kita akan mendengarkan kata sambutan dari Bapak Alexander Fajar Kurniawan selaku Chief Executive Officer dari PT Optik Tunggal 14th. Untuk Bapak Alex Kurniawan, waktu dan tempat kami persilahkan.
Ben, ambil yang naik aja Ben, boleh dipanggil Ben.
Selamat pagi semuanya, dokter-dokter, guru besar, dan tamu-tamu yang datang, dan juga tamu asing kita. Mohon maaf, saya nggak bisa berpantun karena nggak pernah diajar gimana cara berpantun. Jadi saya nggak bisa membalas pantunnya Dokter Nurdin Zuhri ini. Maaf ya. Nyanyi nanti malam, nanti kita bisa nyanyi. Ada waktunya nanti. Anyway, terima kasih sudah datang ke acara Refractive Weekend kali ini. Pertama-tama, again saya mengucapkan terima kasih atas kehadirannya. Thank you for our distinguished guests, Dr. Kudu, Dr. Cronin, and Dr. Tan. Dr. Tan has not arrived, I suppose. And also, thank you so much for Richard White and Oculus, Germany, for coming here. Hopefully, we can actually do something in this event. Sebenarnya, Refractive Weekend ini adalah pertama kali yang kita jalankan ada Optik Tunggal. Karena 2 tahun berturut-turut kami melakukan Retina Weekend Jadi dari tahun 2023 dan 2024. Tetapi saya rasa ada baiknya kita juga mengembangkan ini ke refraktif, karena ini merupakan salah satu bidang subspesialis yang besar ya. Jadi kita berharap dengan adanya event ini kita bisa melakukan sharing knowledge dari para dokter dan sebagainya yang bisa meningkatkan standar praktis yang nantinya akan diberikan kepada pasien di situ. Saya tidak akan banyak berbicara karena ini karena tadi sudah dikatakan juga oleh Dr. Rudin. Tetapi yang penting kami berusaha untuk memfasilitasi event ini supaya bisa berjalan dengan baik dan berguna untuk kita semuanya. Itu sebenarnya yang menjadi tujuan kami. Ada satu hal yang saya ingin share dari sini. Jadi Optik Tunggal itu sudah 96 tahun ini. Jadi dalam waktu sekian lama kami juga berpikiran bukan hanya untuk mencari keuntungan aja, tetapi kami juga ingin mengembalikan itu kepada komunitas, kepada masyarakat Indonesia, khususnya yang membuat bisnis, di mana kami memang memilih satu proyek dan proyek untuk anggota yang terkena congenital cataracts. Jadi banyak sekali yang anak-anak ini yang tidak dirabah oleh kita karena mereka ini tinggal di pelosok-pelosok seluruh Indonesia dan keluarganya itu dari keluarga prasejahtera, sehingga mereka juga tidak mempunyai satu means atau satu kemampuan untuk mengetahui bahwa ini sebenarnya ada loh
sesuatu yang bisa membantu anak-anak mereka. Bayangkan kalau mereka terkena congenital cataracts pada waktu the golden period di mana mereka harus tumbuh kembang. Tentu mereka tidak bisa menjadi seorang yang produktif di situ. Tetapi kami ini berusaha untuk membantu supaya anak-anak ini tidak menjadi seorang yang tergantung dengan keluarganya seterusnya di situ. Itu dia sebabnya sejak tahun 2019 kami itu melakukan proyek untuk mencari keluarga prasejahtera yang anaknya terkena congenital cataracts. Nah, kami memohon sebenarnya, kami minta bantuan dari rekan-rekan dokter supaya bisa untuk melihat nih apakah ada keluarga yang mendatangi dokter yang membutuhkan bantuan tersebut. Karena kalau misalnya ada keperluan dari situ, tinggal mereka diberitahu aja, hubungi Optik Tunggal, hubungi dari Instagram kami atau social media kami, atau ada juga nomor nomor customer relation kami. Nanti kami juga akan sharing di situ. Dan mereka nggak usah melakukan apa-apa. Jadi kami yang akan datang ke sana melakukan pemeriksaan mata terhadap anaknya. Kemudian kami akan order. Ini kebetulan kami ordernya ke Zeiss ya, Zeiss Germany. Dan setelah barang itu datang, tim kami akan datang lagi ke rumah mereka masing-masing dan kami akan memberikan itu. Jadi mereka sudah tidak perlu lagi datang ke kota atau ke mana yang ya tentu butuh ongkos di situ, ya kan? Jadi mereka tidak perlu apa-apa lagi. Kami yang jalankan. Nah, kami memohon supaya para dokter kalau misalnya ada pasien yang membutuhkan, tolong beritahu aja, hubungi Optik Tunggal dimanapun. Ya, itu suatu hal yang kami bisa jalankan. Ini kami ada sedikit klip ya, mungkin ini berguna untuk kita untuk lihat sebentar aja. Ya, saya minta waktu mungkin 1 menit aja, silakan.
Mata adalah jendela dunia. Jika penglihatan tidak berfungsi, banyak aspek kehidupan akan terganggu. WHO menyebutkan sekitar 500.000 anak mengalami kebutaan setiap tahunnya, sehingga dapat dikatakan hampir setiap menit satu anak mengalami kebutaan. Di sisi lain, menurut data Kementerian Kesehatan Indonesia, sekitar 1,4 juta anak di dunia mengalami kebutaan, dengan perkiraan 20.000 hingga 40.000 kasus baru katarak kongenital yang terdiagnosis setiap tahunnya. Selama 95 tahun Optik Tunggal berdiri, kami berkomitmen untuk memberikan pelayanan terbaik. Itulah sebabnya Optik Tunggal hadir dengan memberikan 2025 kacamata untuk anak-anak pejuang katarak kongenital dari tahun 2019 hingga sekarang. Memberikan harapan agar tatapan mereka kembali jelas, senyuman mereka kembali terukir, dan memberikan harapan agar mimpi mereka menjadi nyata. Selain itu, kami memiliki program Free Eye Check. Program ini kami lakukan secara masif di berbagai lapisan masyarakat untuk mempermudah pemeriksaan mata dan membantu mereka yang kurang beruntung. Terima kasih telah mempercayai kami. Mari sebarkan harapan ini untuk masa depan yang lebih cerah. Bersama Optik Tunggal, ayo lihat dunia.
Terima kasih. Kalau dokter tahu kan ini anak-anak ini butuh lensa yang tebal sekali, yang sampai bisa plus 23 dioptri. Jadi tebal sekali itu. Nah, lensa yang kita siapkan itu adalah lensa yang sudah diproses sedemikian rupa sehingga menjadi tipis dan ringan, sehingga anak-anak tersebut tuh masih tetap bisa menggunakannya tanpa berasa terbebani di situ. Dan anak-anak ini bukan hanya kami berikan sekali, karena setiap setahun sekali atau 2 tahun sekali mereka akan kami datangi lagi dan kita ganti lensanya karena pasti ukurannya akan berbeda. Dan kami akan lakukan itu sampai mereka itu cukup umur untuk diimplan IOL. Jadi kira-kira sampai 9-10 tahun, kira-kira begitu. Dan ini adalah komitmen kami di situ. Dan pasti susah itu karena terus terang aja kalau harga lensanya itu aja pun mahal sekali. Ya, dan again kami sudah 96 tahun di sini, saatnya lah kami memberikan kembali kepada masyarakat Indonesia. Jadi saya memohon kepada rekan dokter, tolong kami sebarkan berita ini dan kami yang akan menjalankannya. Terima kasih semuanya. Kita ada waktu 1 hari dan nanti malam kita akan berkumpul juga untuk makan-makan dan bernyanyi ya dok. Jadi silakan dinikmati, semoga event ini berjalan dengan baik dan sukses. Terakhir terima kasih pada semua panitia atas usahanya. Kita sudah jalankan persiapan ini sudah kira-kira 5 bulan ya. So terima kasih semuanya. Selamat pagi, silakan menikmati.
Boleh kita berikan tepuk tangan. Terima kasih Pak Alex sekali lagi. Terima kasih untuk hatinya ya. Terima kasih untuk support selalu kesehatan masyarakat Indonesia. Baik, Bapak Ibu dokter dan juga tamu undangan sekalian. Kegiatan hari ini akan dibagi menjadi 2 bagian. Jadi untuk para dokter dan juga tamu undangan sekalian, diharapkan untuk bisa mengikuti keduanya ya. Pada LMS Symposium ini sudah dibuka dari jam 7 pagi, sementara untuk workshop sudah dibuka mulai dari jam 9 pagi. Baik, tanpa berpanjang kata, kita akan memasuki sesi inti yang tentunya sudah kita nantikan bersama, yaitu sesi pertama dengan judul Topografi Biomechanics, the Corneal's Refractive Surgeon's Need, di mana seluruh sesi pada hari ini akan dimoderasi oleh Dr. Ria Sandi Deneska, spesialis mata konsultan. Saya bacakan terlebih dahulu untuk CV-nya yang nanti di mana Dr. Ria Sandi Deneska ini akan juga didampingi oleh panelis yang akan bergabung di saat sesi diskusi. Saya akan membacakan CV untuk moderator. Dr. Ria Sandi Daneska, spesialis mata konsultan. Saat ini beliau menjabat sebagai staf pengajar dan juga konsultan di Fakultas Kedokteran Universitas Erlangga Surabaya dan juga sebagai konsultan di National Eye Center Surabaya. Sementara untuk para panelis, para dokter dan juga undangan sekalian, ada Dr. Ucok Parlindungan Pasaribu, spesialis mata konsultan, yang saat ini beliau menjabat sebagai konsultan bedah refraktif di Mayapada Eye Center, Jakarta, Indonesia. Kemudian ada Dr. Dini Dharma Widyarini, spesialis mata konsultan. Saat ini beliau juga menjabat sebagai konsultan bedah refraktif di Rumah Sakit Mata Undaan Surabaya dan juga sebagai konsultan bedah refraktif untuk National Eye Center Surabaya. Last but not least, untuk panelis ada Dr. Emi Dwi Sugiyarti, spesialis mata konsultan magister kesehatan, yang saat ini beliau menjabat sebagai konsultan katarak dan bedah refraktif untuk Pusat Mata Nasional Rumah Sakit Mata Cicendo Bandung dan juga sebagai kepala klinik eksekutif dan klinik lasik untuk Pusat Mata Nasional Rumah Sakit Mata Cicendo Bandung. Baik, untuk Dr. Ria, waktu dan tempat kami persilakan untuk memulai sesi pertama pagi hari ini.
Terima kasih. Tes. Terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi kepada semua hadirin. Pertama saya mengucapkan terima kasih kepada seluruh peserta yang meluangkan waktu di weekend ini untuk tetap berkegiatan ilmiah. Memang kalau dokter itu weekendnya tidak bisa santai-santai kegoleran ya dok ya. Jadi kita itu kalau tidak ikut ilmiah, baksos, operasi, praktek, kadang masih ada webinar. Jadi alhamdulillah pagi ini kita bisa mengikuti kegiatan refraktif weekend. Terima kasih juga kami sampaikan kepada para pembicara dan thank you to our distinguished speakers. Baiklah, untuk menyingkat waktu karena waktunya sudah berjalan mundur, kita akan memulai sesi pertama. Kami persilahkan kepada para pembicara untuk naik langsung ke panggung. Please to our speaker to come to the stage with us. Untuk sesi pertama, kita akan ada tiga topik, satu topik tentang topografi dan tomografi dan 2 kasus. Topik pertama akan disampaikan oleh Dr. Brendan Cronin. Dr. Brendan Cronin, CV-nya mungkin bisa ditayangkan. Beliau akan berbicara mengenai using topography, tomography, and biomechanics to identify and treat corneal diseases. Ini adalah CV dari Dr. Brendan Gerard Cronin. Bisa dibaca sini. Okay, Dr. Cronin, you have 40 minutes to present your topics.
Okay.
Okay, please, the floor is yours.
Thank you very much. It's my first time in Surabaya, so it's a pleasure to be here. So far, I've seen a bit of the city, and it's beautiful. So I'm from Brisbane in Australia. I have a wife and 2 daughters, and when they say to me, "Daddy, who do you love the most?" I say, "That's easy. There's 3 of you. I love keratoconus." Yeah, I've tried. So, here we go. So, I'm going to cover topography, tomography, and corneal biomechanics. And I guess the question is, why do people want a Corvus? Why do you need a Corvus? I always laugh when I see so many refractive surgeons, they say, I never have ectasia. And I always say to them, oh, I've seen like 15 of yours. So I do a lot of keratoconus and LASIK. And what happens is a patient has LASIK, they then go back to an optometrist 10 years later and say, I don't see very well. Optometrists all have topographers these days, at least in Australia. You know, they can get a cheap one that sits on their slit lamp. And the optometrist says, oh, you have post-LASIK ectasia. I'll send you back to the surgeon who did your LASIK. And the patient says, no way. I hate that person. He gave me blurry vision. I'll see someone else. So they never go to the surgeon who did their LASIK. So it's like when you see an orthopedic surgeon and they all say, I never have a patient get a DVT after their hip or knee. And the poor physicians on the ward are saying, oh my gosh, all I do all day is treat the DVTs from the orthopedic surgeons. So that is why I think that biomechanics is an enormously advantageous addition to any clinic that looks at corneas or wants to do refractive surgery. So car tyres. So I hate glaucoma. Glaucoma is boring. At a glaucoma conference, all they do is talk about one number, the IOP. I never want to see glaucoma. But the Corvus is very good for glaucoma if you're a glaucoma surgeon. It's also very good if you're a corneal surgeon. You can say, there's something weird about the pressure. Go to a glaucoma surgeon. So how do we measure the pressure in a car tyre? When you pull into the service station to check the pressure in your car tyre, you don't kick the tyre with a machine, or with your foot to work out, or a machine to work out the pressure. You connect the pressure in the tyre to something that reads the pressure inside it. But we don't have that for the eye. So what we're doing with the eye is effectively just kicking a tyre and assuming that every tyre is the same. And they're not. In tyres there's variations, and in corneas there's variations as well. So measuring the pressure in an eye is enormously dependent on biomechanics. And all pressure measurements, except for the Corvus, assume that all corneas are the same, and they're not. So what are we doing in biomechanics? We are taking the biomechanics of the eye and factoring that into pressure. So it's an enormously advantageous feature that I'll show you briefly coming up for any surgeon working in ophthalmology. Obviously, I'm more interested in the ectasia features of the Corvus, diagnosing keratoconus and working out which patients we can do laser on. So these are the machines. That's the Oculus Corvus. It's a very quick, easy to use machine. It gets a puff of air on the eye and it does super high speed, high resolution images of how the cornea deforms in response to that very set stimulus. It gives you a little video of the cornea deforming. Patients love to see it. If patients have keratoconus or if they have a cornea that's a little bit weak for LASIK, you can show them the video of their eye deforming on the Corvus software, which is networked in the clinic, and say, see how your cornea moves too far away in response to that puff of air? It shows that it's not strong enough. The shape of a cornea, we have always assumed that the shape of a cornea, that the topography inferred the strength, which it often does, but not always. And that's the advantage of the Corvus. So, as I say, I hate glaucoma. I do not want to see glaucoma in my clinic. It makes me want to go to sleep. If I can't sleep on the plane on the way home tonight, I will just think about glaucoma and I will be asleep very, very quickly. That's my one true love, cares for keratoconus. So I do not want to talk about glaucoma. I want to do cares. It's my mission. Find more keratoconus, do more cares, do more LASIK. Okay, but let's cover why in any clinic where sadly we have to see the boring disease of glaucoma, the Corvus is advantageous. So this was a lady I saw. She had gone to her Year 12 formal with the big glaucoma professor in my town. And she was 32 years old. She had a pressure that was always 36 on Goldman and other types of tonometry. She was on Lumigan, and she had prostaglandin-associated periorbitopathy. She had red eyes, dark black eyes. She did have wonderful eyelashes, but that was the only thing she liked about her glaucoma medication. And she was ready to have a tube with the man she went to her Year 12 formal with, the professor of glaucoma. And she just came to see me for dry eye. And I said, okay. I put her on the Corvus, and I said, oh, hold on. You don't have glaucoma. And she said, what do you mean? I'm having my tube next week. I'm having a Barvelt tube for my glaucoma. I'm going blind. And I said, oh, no, you're fine. Everyone's wrong. The pressure is normal. Everyone has just assumed that the machines measuring the pressure were right, because that's what we all assume. That's what we all got taught. But it's not right. When you factor this lady's biomechanics into her pressure was perfectly normal. And as you can see, I followed her here over a fairly long period of time, though they were this is when I first saw her. She said, well, I'm freaking out. And I said, okay, just come back all the time. Come back once a month, and I'd stop your drops, and come back once a month, and we'll see what the pressure does. And the pressure got lower when she stopped her Lumigan. So the first one up there is, the red doesn't work. That's okay. The first pressure, 24, was when she saw me on Lumigan. I stopped the Lumigan, and over time it didn't do much, but ended up at 18. And I still see her now. She hasn't had glaucoma surgery. She doesn't take Lumigan. Her nerve is perfectly healthy. She doesn't have glaucoma. She just has a stiff cornea. And when you measure her stiff cornea for pressure, it thinks the pressure is high when it's not. So Corvus can be enormously advantageous in glaucoma clinics. Okay, so she's been off for years. She buys me presents every time she comes, which is really nice. Except last time she bought me flowers, and my wife's allergic to flowers, so I brought them home and I had to throw them away. Okay, so what about normal tension glaucoma? I hate normal tension. I hate all glaucoma, but not hate. I don't love glaucoma. Normal tension glaucoma is so hard to diagnose, and patients come in and, oh, is this glaucoma? Is it normal tension? You have to see them. Very uptight patients want an MRI. Could it be a brain tumour? And you follow them forever and you can't do much for them. You can't do LASIK on them. Boring. And they don't have keratoconus. Boring. But biomechanics can tell you if they have normal tension glaucoma. So biomechanics, just with one Corvus scan, with a 78% sensitivity and a 79% sensitivity, can tell you if that patient has normal tension glaucoma. So that's fantastic. Then I can say, good, go away, never see me again, go to the glaucoma specialist. Or you're probably fine, let's do laser. So it's fantastic for screening normal tension glaucoma. I don't know how anybody who treats glaucoma doesn't have a Corvus to assist with these patients. My glaucoma specialist, I have 2 of them in my clinic, and I like them. They're my friends because they see glaucoma, so I don't have to. But when I got my Corvus for LASIK screening, they said, oh, yeah, what's this? They were playing with it. Now, I can't get my LASIK patients onto the Corvus because there's a line of glaucoma patients queued up to have their pressure done with the Corvus. So this is what it does. It tells you where your patient sits on a normal population and what their chances of getting normal tension glaucoma are. So, excellent. Let's skip over glaucoma. I don't want anyone to go to sleep. But the Corvus is enormously advantageous in looking at glaucoma progression. Even if they have glaucoma, normal high pressure glaucoma, you can look at the stiffness parameters to work out which of the patients who are more likely to progress. So anyone who has an interest in glaucoma, I'm very sorry to hear that, but the Corvus is very useful in that disease. Okay, so let's look at ectasia. Let's get excited because everybody loves keratoconus and corneal ectasia. So it is time to move on from standard topography. We've had topography for a long time. It is fantastic. It has got so much better. It has wonderful indices for detecting ectasia, but it doesn't tell us how strong the cornea is, and we're missing out on a whole lot of information. Now, sometimes as surgeons, we can also get too much information. You get these screens and there's numbers everywhere and higher order aberrations and Q values and angle kappa, and you think, oh, I just want one number. Can I do LASIK or not? We've got it. So the Corvus gives you this number here, which is down the bottom. Be great if I could get a laser pointer, if there's a laser pointer, but this number right here, the TBI. And if that is under 26 or 0.26, you can do LASIK. So it just gives you an answer. Can I do laser or not? It makes it so easy. It gives you a number. It's fantastic at screening. You just do not see post-LASIK ectasia. But importantly, you're not ruling out a whole bunch of people for laser that you otherwise would have done. I think you end up doing more laser. So let's have a look. So there are some fantastic things you can do with biomechanics. You can treat customized corneal topography based on the biomechanics of the cornea, thanks to these guys who are amazing. So you can, that one's good, awesome. Thanks, mate. So look at this eye. This was courtesy of Rohit's team from the guys who've created amazing software. This was a cornea before cross-linking. We plugged the raw data from the Corvus into this fantastic software called AcuSimX. It told me, Brendan, cross-link this cornea at this point, and it mapped out the treatment for me. And so that was this patient's cornea before cross-linking, and that is this patient's cornea after cross-linking, and that is a map of the difference. That cornea is now a perfectly normal shape. There is no one in the room that would look at that cornea and say that patient has keratoconus. If you think they do, that's bad. But they did have keratoconus, but now their cornea is a perfect shape. And so the amazing things that we can do with understanding where a cornea is weak is the future of ophthalmology. I've even shown changes in corneal biomechanics after corneal collagen cross-linking. So hopefully this year, transepithelial accelerated cross-linking will be approved by the FDA in America, and so then it will become obviously more accessible around the world, but we've shown improvements in corneal biomechanics a long time after corneal collagen cross-linking, so at 6 months. So the Corvus can demonstrate post-cross-linking stiffening to you. Patients really, really like this. It will tell you basically tells you this cornea is stiffer and stiffer and stiffer. Corneas often get a little bit thinner for a while after cross-linking. So it enables you to look at patients with really weak biomechanics, if you're doing ectasia, to work out, have you strengthened their cornea enough? There are people, and I'll show a great case of this later on, but biomechanics is brilliant for following up for following up keratoconus, for working out who to cross-link, for working out who you don't need to cross-link, and really treating your keratoconus there. So if you have a look up here, this is how the stiffness parameters of a patient with keratoconus improve after cross-linking. You don't have to look at this in clinic. You don't have to pour through graphs and charts and understand all of these complex numbers. As I say, the beauty of the Corvus is it just gives you a number. Stiffer, better. It's fantastic. It is so easy. I could train my children to look at it. In fact, sometimes over the dining room table, everyone will say, "How was your day?" And I'll say, "Fantastic. Look at this beautiful case of ectasia that I treated today and the wonderful improvement in corneal parameters." My children don't find it as exciting as I do. They don't ask me how my day was anymore, but occasionally I do make them watch this anyway. You can see here, so this is a patient prior to keratoconus, prior to cross-linking, and the same patient has improved in their stiffness parameters in every parameter with some fantastic, with a cross-linking treatment with a fantastic improvement in corneal strength. So this patient, now that they've had cross-linking, is discharged. I never have to follow that patient up again. I know who I have to keep seeing after I've cross-linked because I look and say, oh, all of your corneal stiffness parameters are fantastic now. you can go home. Your keratoconus will never get worse. You are discharged. You do not need to come back to me every year for the next 20 years. So it lets me discharge patients from clinic so I can get new ones in without having an enormous wait time. Okay, so let's have a look here. If someone is coming into your clinic for LASIK, I love LASIK. LASIK's so good. Or PRK, I love laser. I love lasers. If a patient came into you with this and this is their topography, you would say, yeah, you can have laser. No problem at all. I'll LASIK you. They're -3. Their bad D is in the green zone. This is what we've always used for laser screening, the bad D. 512 microns, you're fine. Everything looks fine. Posterior elevation is fine. This is a perfectly shaped cornea. This cornea has a perfect shape. Everyone on earth would laser this cornea. I did epithelial thickness mapping. It was also perfect. But this cornea is weak. So this is the corneal biomechanic index. What the oculists have done is they've incorporated your topography, your tomography, and your biomechanics into one integrated display. This is what we do for everyone in our clinic. And it takes your topography, which is your bad D here, your biomechanics, which is your CBI here, and integrates it into this TBI number. And as long as that TBI is bad, if you laser that cornea, they are going to get ectasia. So without the corvus, this patient would have had LASIK and would have had a bad outcome. So the corvus makes LASIK safer, and the corvus makes screening for LASIK idiot-proof. You just get a number. 0.9, bad. Less than 0.26, good. You can smile. 0.26 to maybe 0.32, you might be able to PRK, depending on the prescription. Okay, let's have a look. So integrating it all takes it into the next level. Let's look at keratoconus, my first love, my greatest love. I know you all love keratoconus too. I know you're excited. So Kmax and central corneal thickness for screening for ectasia, pellucid, keratoconus are ancient parameters. Nobody should be looking at their keratoconus patients and looking at their Kmax and their central corneal thickness and saying, oh, no progression, you're fine. That is like that ancient pyramid compared to this modern pyramid. So everyone should be using the ABCD printout, the ectasia progression display on the pentacam, because it is much more sensitive. It is much more specific. It is much more accurate for screening for ectasia progression. And it is easy to use. Again, it's one of these screens that you look at and say, oh, there's a lot of colours and a lot of numbers there. But once you understand what it is very easy to understand. Okay, A is for the anterior radius of curvature for 3 millimeters around the thinnest point of the cornea. B, for back, is a 3 millimeter radius of curvature centered around the thinnest posterior segment of the cornea. So A is the front, B is the back, C is the central corneal thickness, and D, to be honest, we don't use much. The distance vision, I have basically never seen a patient where the vision drops off where the topography hasn't changed, but that sounds nicer, A, B, C, D. And you can add in E for the elasticity for corvus, but A, B, C gives you a fantastic way of screening for keratoconus. Okay, so let's have a look. So progression. This is all you have to know, 2 points for understanding this whole ectasia display. So progression is indicated by a change in 2 of the parameters on ABCD above the 80% confidence interval, and I'll show you the image. So 2 at 80% or 1 at 95%. That's all you need to know. So let's look at it. So it gives you 3 populations. Green is good. Green is the normal population. Red is bad. Red is the keratoconus population. And blue, whilst wonderful, you don't have to know anything about. So what they've done for this is look at the post-keratoconus population after cross-linking, and basically you can't use topography for 12 months after cross-linking to work out if they're progressing. So that is blue data. I never use the blue data anymore because after I've cross-linked them, I look at their stiffness parameters, and if their stiffness parameters are fantastic and they've improved, I say, goodbye, your keratoconus is never getting worse. They're done. They're discharged, they're fixed for life. So you don't have to know too much about the blue stuff. So, the green gates. So as I say, this is just the normal population. If someone is in the green gates, they are good, relax, job done. The red gates, keratoconus. If someone is in the red gates, and I'll show you the gates in a minute, you can say if they're at the 80% mark, that there's an 80% chance it's keratoconus or progression of keratoconus. And if they hit the 90% mark, you can say your keratoconus is worse. You are having corneal collagen cross-linking. The blue gates, as I say, blue gates are just corneas change after cross-linking. Corneas change wildly and erratically and consistently after corneal collagen cross-linking, so you don't look at A, B, C, D for 12 months after cross-linking. And I would argue that if their cornea is a lot stronger, you probably don't need to look at them at all. Okay, so let's have a look here. It looks like a lot, but it's really easy. So we have a patient up here, left eye, right eye. So this is two eyes. I've just put the A and B on. A and B are easily the most important two parameters. Easily the most important two. 99% of your ectasia is detected with A and B. And so here, this patient here, so one scan in 2024, one scan in 2025. When they first came in, everything was in the green zone. You are 80%, remember the green is the normal population, green is good. So it was saying, yeah, you're fine. You are well in the normal population in your left eye and your right eye, you are well in the normal population. You might say, Brendan, why was this patient even seeing you? Their topography is normal, totally in the normal population. Because the optometrist has a corvus. And the optometrist sent it in to me and said, Brendan, this patient has normal topography but quite a weak cornea, and they rub their eyes a little bit. What do you want to do? And I said, send them to me. So I said, right, here's the deal. You have a perfect corneal shape. You rub your eyes. We stop the eye rubbing. But she was young. She was about 17. Let's get you back in about 6 months' time. She came back 6 months later. So that's the green bar. And you can see there is an 80% chance just on the A, on the anterior radius of curvature, that she is in the keratoconus population. 80% isn't perfect. If it was just that, and if you were just looking at anterior curvature, you would miss that she's progressed. But then when you look at B, remember B is the back, the 3 millimeter zone around the thinnest point of the posterior cornea. She has progressed right out. See, here's the keratoconus, 95% chance she's in the keratoconus population and beyond. She has progressed just on B alone because she's gone into the, remember, 95% zone. So 2 parameters in the 80% keratoconus zone is progression, 1 parameter in the 95% keratoconus zone is progression. So she has progressed in her left eye just on B alone, A and B together, she has progressed. She still has good vision. In the right eye, exactly the same picture, but it's worse. In the right eye, well, I argue actually it's not worse. She's in the 80% zone there, and she's in the keratoconus 95% zone there. I want you to notice something that's really important on these scans that people get confused by. Where the gates are is not the same. There is not an absolute, the algorithm is complex, but we don't need to understand all of the complexities behind the algorithm. So the algorithm has taken thousands of cases and worked this out. If you have a look here though, the gates are at different spots. Say the keratoconus zone for this left eye here on the anterior radius of curvature, 80%, is at about, 1.35. See, 1.2, 1.4, about there. Whereas here, the 80% zone is at 2. They are not absolute numbers, but you don't need to know them. You only need to say, what gate is your line at? 80%, 95%. So it's a brilliant formula. There's a massive amount of work that's gone into it by Michael Bell and in behind the scenes, but we don't need to understand all the complexities. You can be really dumb and still do cornea. I tell my children that sometimes, or maybe they tell me. We just want a number. You want a TBI. You want something easy. Oh, 95%, you are worse, you need something done. So the Corvus makes life easy. Okay, so let's look at this patient. If you just had a Pentacam and this patient came into clinic, you would say, oh, you're no worse. 48.5, steep there. 47.8, oh, you might even be a little bit better. Wow, that's cool. Maybe you stopped rubbing your eye. You would look at other things. You might say, oh, pachymetry 511 to 503, that's nothing bad at all. That's not a big change. So nothing is dramatically different between these two corneas. There's some subtle change, but not much. Look at the Ks. K1 44.4, 44.3, no big change. K2 46, 46.2, tiny axis change. There's nothing that's a big deal here. So you'd say, oh, you're no worse, you're fine, go home, come back in 1 year. This is the ABCD progression display of the same patient, the same scans. So, first scan, second scan, 80% chance it has progressed into the keratoconus population. On B, 95% chance they have progressed into the keratoconus population. And on the corneal thickness, 95% chance he has progressed into the keratoconus population. The ABCD progression display is more sensitive and more specific at picking up progression of corneal ectasia than any other parameter. It is easy to use. Don't be overwhelmed by the colours and the numbers. It's really easy. Just look and see if the bars have gone into the red 80 or the red 95% zone. Okay, left eye. This one's even fewer change. I find this one amazing. That first change you could look at and say there's a few little subtle changes, but look at this. This is the difference map here. There is no difference between these two scans based on the anterior sagittal curvature. There is no change. If you look at that as your screening change, you'll say, oh, cornea is the same, go home, bye-bye, lovely to meet you, hope you have a nice day. So this cornea is the same on the anterior curvature. Again, look at ABCD. So work out in your mind, have a look at the scan and say, right, what do I have to do for this patient again? Remember, do we have the second bar? So if they come over multiple appointments, there will be multiple bars. That's okay. These are just cases where I've just picked cases where they've just come in twice and I've shown the progression. But green line, 80% keratoconus. The green line is just the second line, the second assessment. Posterior radius of curvature, way into the keratoconus zone, and the corneal thickness, again, into the 80% keratoconus zone. This patient has progressed. This patient has progressed significantly. Their vision hasn't changed, but we can cross-link them now with evidence of progression and keep their vision the way it is. Then I can do their corvus, see that the cornea is stronger, and say, Mum, your child is fine. Your child's keratoconus is not getting worse now. The cornea is much stronger. Everybody can relax. Okay. I love this young girl. She has quite severe trisomy 21 or Down syndrome. I just can't get good topography on her. She has nystagmus. Whilst she's lovely, she can get a bit aggressive. She won't sit still for us to do scans for her keratoconus. And I'm sure, I can get a sort of scan, it shows keratoconus, but it's not good enough to look for ectasia. I just can't do it. But I can get a corvus on her, because it's very quick. So, she's come in and again, look at all those bamboozling numbers. This is where Oculus are amazing. If you love numbers, if you're a savant and you want to explore numbers, you can do amazing things with an Oculus device. But you can also just look at one number and say if they're worse. So this is the E in A, B, C, D for progression. So I can't look at her topography and work out if she's progressed, but I can look at her biomechanics. So have a look here. This is the E staging of keratoconus. 0 is great, 1 is bad, 2 is worse, 3 is even worse, 4 is shocking. So higher numbers are bad. First 2 times I saw this girl, her E staging had not changed at all. And I can get a great corvus on her even with nystagmus and a fairly non-compliant patient. The corvus is quick. Next time she came in, she had progressed. Her cornea was more elastic. Her cornea is weaker. She is progressing. We need to cross-link her for her keratoconus. So it's a really nice documentation that you can't always get perfect topography, and that biomechanic deterioration in their cornea is deterioration in their keratoconus. Okay, so E-staging can confirm progression. So, any questions about keratoconus? Screening for LASIK, so easy, one number. Anybody? I apologise if any of you really like glaucoma. Yeah. If we got a microphone we can hand around.
Hello, good morning, sir.
Hi.
My name is Budi Surahman. I come from Surabaya. Thank you very much for your information. Maybe I would like to ask, when we start to examine the patient, then we have the patient with keratoconus. So usually we use the LASIK extra for the treatment. Then I want to ask, if we treat the patient with the LASIK extra, so when we know that the keratoconus is already stable, or is there any some issue when after many period the patient should also have another treatment? Thank you. Maybe it's...
Sorry, you're saying if they've got keratoconus to do LASIK?
Yes,
you're saying,
yes.
I don't do LASIK in keratoconus patients. I do PRK, or you could call it PTK. So yes, I gather what you're saying is, yeah, they have keratoconus, you might cross-link them first, or you might say, okay, you have keratoconus, you don't have good vision, you can't wear a hard contact lens, you want better vision, and I talk to them about options, and the main 2 options, if they can't wear a hard contact lens, are CARES, corneal allergenic intrastromal ring segments, or a topography-guided laser treatment to try and regularise their cornea. I wouldn't do it as I wouldn't do it as LASIK. You can't topography guide smile. I wouldn't do it as LASIK. I would do it as a transepithelial PRK type procedure and cross-link them at the same time. Yeah.
Okay.
Is that your question?
Okay, yes, thank you.
Yeah. Yeah.
Yeah, as a refractive surgery, sometimes we do check the IOP. On your first slide, you're talking
Terrible, isn't it? IOP. Ugh.
Yeah, okay. I mean, until now, we are still struggle with the patient to check the IOP after the LVC. So I just, maybe last year, I attend a meeting at the Innovation Day in ESRS. They talk about the new technology that can measure the IOP with the patient very accurate after patient with the LVC, LASIK of smile. Yeah. So you compare to that tools, how about the Corvis? You can really convince that this is a good one to check the IOP after the LVC. Thank you.
Yeah, what we always do Corvus after we do any refractive surgery, because it also has a number on it that tells you if they're going to get ectasia or if they have ectasia. You know, sometimes you see a post-LASIK patient and they had their LASIK 10, 15 years ago and their ablation is a bit decentered, and you look and say, is this ectasia or not? If you do biomechanics, it just says ectasia. You just click that they've had LASIK and it will say ectasia. So we look at that after LASIK to make sure we're in the safe zone, just in case somehow something has been missed. We haven't had any, thankfully. But yes, so we use it for our IOP post-LASIK. The funny thing about Corvus is most patients, I think for glaucoma surgeons, I don't do glaucoma, I hear what you're saying. Most patients who come in with a normal pressure and no suspicion of glaucoma, the Corvus and the Goldman or the eye care all match up. But those patients who have a normal pressure and their nerve is getting worse, for the glaucoma specialists, when you do their Corvus, it either says they have normal tension glaucoma, or sometimes it says their pressure isn't 15, it's 32. And so your normal patients that you aren't worried about, the Corvus doesn't change too much. It's the patients where you say, oh, have you got normal tension glaucoma? Or it's the patients who have a really high pressure but no glaucoma progression, that it often says, no, everyone can calm down, the pressure is normal. So yes, it is great for pressure post-LASIK, but often the pressure doesn't, I'm amazed, but often the pressure is just a few millimeters of mercury different. So your normal post-LASIK population, not a problem, but if they develop glaucoma, then yes, and they've had LASIK, the Corvus is very helpful.
Okay, thank you.
Yeah.
While she's coming up to the microphone, just to add on to that from, as he said, per the studies, pre-LASIK, post-LASIK, this is the best ability possible from the studies that we have. There's about 50 of them peer-reviewed and published that we can get you. But as you said, the IOP might still go up and down 1-2 millimeters of mercury, because we have to remember it's also on the heartbeat, right? So that there is some sort of fluctuation there that we don't adjust for, but still, as far as what we do is we take the true biomechanics out of the equation. So therefore, you're left with just the IOP. So therefore, post-LASIK, you have the most stable.
Yeah.
Yes. Thank you, Dr. Cronin. That was an enlightening presentation. So I'm a bit curious about the case that you got referred from an optometrist asking that this patient had an unusual CBI and then got referred to you, but the topography was quite normal. And then, but you decided to just follow up for 6 months and then looking at the ABC, and then it shows progression. But in this kind of cases, so the second follow-up, the topography is still normal, but the ABC is showing progression. Is that what you were saying in that case?
Well, topography, I think I get your question, but topography isn't just the shape of the front of the cornea. That's the thing about ABCD. If you want to look at topography, being it anterior topography, to look at progression of ectasia, so many patients progress on the posterior cornea before they progress on the anterior cornea. And the thinnest point can move and change even before the anterior topography changes too much. So that patient was a bit different. That patient's optometrist has a Pentacam and a Corvus, and our optometrists in Australia manage a lot of glaucoma. So, and that optometrist does complex contact lenses. So she was just in there to get orthokeratology, ortho-K lenses. And so the optometrist did the scans and said, oh, these corneas are a bit weak. They look normal, they're a bit weak. Go and see what Brendan says. So I followed them up. But yeah, so ABCD is just a really smart way of looking at different topographic layers to look for progression, as opposed to just standard, I look at the front, looks the same, you're fine. Yeah.
But on the progression of the keratoconus itself, the threshold of doing cross-linking, do you actually see also, say, if you receive a patient for the very first time and then the CBI is showing that it's a weak cornea, would you go right ahead for cross-linking, or do you still do a follow-up in 6 months?
That's a great question. There's no black and white answers with this. If the patient is young, and I guess my matrix is if a patient comes in with keratoconus and they rub their eyes a lot, you have something to modify, and that's eye rubbing. So I very rarely cross-link them when I first, on diagnosis, because I say, look, we can do something to stop your keratoconus getting worse. Let's manage your allergies and stop you rubbing your eyes. And I've seen their corneal biomechanics improve. If a patient comes in and they don't rub their eyes, you don't have too much that you can alter with their disease progression. So if they're young and a teenager, then I'm much more likely to offer cross-linking. So I'll often say to the parents, look, this is probably going to get worse without cross-linking, but we could watch you, and if the biomechanics are weak, I'll watch them closer. If they're 25 or 26, I'll be more relaxed. But yes, I do look at the biomechanics. Well, in reality, most patients with keratoconus have terrible biomechanics. It's rare to get one in the orange zone. They are often far into the red. But it lets you show the parents and the child or the patient the disease, show them that it's weak, they understand it better. But in terms of my first appointment, does it alter much of what I do? Not too much. Though occasionally, I saw an optometrist in Brisbane, she does most of the contact lenses for patients with keratoconus in Brisbane, and she came in and her son's topography was a bit abnormal. It looks like keratoconus. She was freaking out. He was blaming his mum, saying, I caught this from one of your patients. But his biomechanics were fantastic. He just rubbed his eyes a lot. Changed his topography, probably his epithelium a bit from some papillae. And so I followed him up for a little while now and he's stable. So it helps, definitely. Yeah.
Is there actually a lot of cases where the topography difference is not showing any change, but then the ABC is showing progression? Is there actually more percentage towards those cases, or?
I don't even look at topographic, I don't look at those topographic comparison maps anymore. I use ABCD.
Okay.
ABCD is the best evidence for looking at ectasia progression. I don't look at the topography. When I walk into the room, my assistants have brought up the ABCD display.
Right. And in terms of cross-linking, you were saying if you're doing a PTK, like transepithelial PTK, how about just standalone cross-linking? You do epithelium off, or you also do transepithelial?
Oh, I've got that fancy machine from Glaucos, the transepithelial oxygen-enhanced topography-guided one, so I'm a bit lucky. Yeah, I don't have to scrape off epithelium
anymore.
Yeah.
Okay.
Yeah.
Thank you very much.
No, thank you.
Okay, sorry, Dr. Cronin and the audience, maybe if we have further question, we can continue to discussion session because we have very limited time. Okay. Thank you, Dr. Brennan Cronin, for your interesting and very insightful presentation. Kita lanjutkan dengan presenter kedua, Dr. Joan Huta Barat, untuk mempresentasikan case reportnya. Mungkin bisa ditayangkan CV untuk Dr. Joan. Dr. Joan adalah staf pengajar di Rumah Sakit Mata Cicendo dan spesialis mata di Dago Vision Center.
Oke, thank you. Terima kasih Dr. Nika untuk perkenalannya. Maybe I would like to ask to present in Bahasa, if you don't mind, but we will discuss in English, I think. Jadi mungkin saya akan bawakan satu case mengenai keratokonus. Oke. So di pasiennya 24 tahun, female. Datang referral from another ophthalmologist that have been seeing her for last year. Jadi keluhannya memang dia ada blurred vision, 1 tahun terakhir sangat terasa seperti bertambah, terutama di mata sebelah kanan. Dia sudah pernah pakai kacamata tapi nggak pernah nyaman dengan penggunaan kacamatanya. kemudian memang dia ada alergi dan juga ada kebiasaan untuk eye rubbing, tapi nggak ada any other ocular disease. Oke, dari visual acuity, yang mata sebelah kanan 0.08, yang mata sebelah kiri 0,8, dikoreksi yang sebelah kanan masih paling baik bisa dengan 0.4, dan sebelah kiri bisa 1,0. Untuk dari anterior segment, I think it's all within normal limit. Untuk papilanya juga hanya sedikit. Posterior within normal limit also. Kemudian yang kita lakukan corneal tomography examination. Waktu itu untuk mata sebelah kanan K1-nya 43,2, K2 48,3 dengan rata-rata 45,6, astignya terbaca minus 5.1 dan tinus korneanya di 468, Kmax di 54,2 dan progression indexnya 1,45. Berikut adalah gambarannya. Kemudian untuk mata sebelah kiri relatively normal. Saya kira ini kita ada, oke nggak apa-apa kita lanjutin aja. Untuk diagnosisnya, oke. Mata sebelah kanan keratokonus dengan A2, B2, C2, dan D2, dan untuk yang sebelah kiri kita masih DD dengan formefluste keratokonus. Next, the manage untuk yang first, advice to stop eye rubbing. Yang kedua, kita lakukan corneal collagen cross-linking because she was referred to do the collagen cross-linking. The past ophthalmologists have been seeing her for last year, and then we do follow-up. Next. Untuk mata yang sebelah kanan, untuk kontrol ini 1 bulan pertama, in the first month, kurang lebih masih sama. Next lagi. Untuk mata sebelah kiri, sekalian kita lakukan untuk kontrol juga, relatively the same. Untuk mata sebelah kiri. Next. Kemudian kita akan manage dengan follow up. Sorry, ini corneal collagen cross-linking only on the right eye, not the left eye. So, and then we plan to do contact lens fitting because he wants to go study abroad in the next 2 or 3 months, I think. And then next. So this is the perbedaan dari ketika sebelum CXL, 2 bulan setelahnya dan 3 bulan setelahnya. Biasanya kita lihat sampai 6 bulan, cuman karena memang ini kasus yang berbeda karena pasiennya memang akan sekolah ke luar negeri, jadi dia butuh untuk penglihatannya untuk lebih baik. Next. Ini untuk ABCD progression display-nya untuk yang mata sebelah kanan. Cuman memang di sini case-nya mungkin tadi kita agak touch ke pertanyaan sebelumnya bahwa di sini memang case-nya pasien referral sudah dilihat 1 tahun sebelumnya dan memang untuk di refer untuk dilakukan cross-linking, so we do cross-linking in the first session I've met her. And then ini untuk mata sebelah kiri kurang lebih juga masih sama tapi baru 3 bulan, not 6 months, only 3 months follow up. And then next. Oke, this is for the ABCD untuk mata sebelah kiri, jadi relatively aman, dia masih di 80% normal population. Next. Oke, so we do a contact lens fitting in her right eye, I think kita bisa langsung next aja. Dan visus untuk yang sebelah kanan setelah dia pakai corneoscleral lenses bisa lebih baik. Next lagi. So maybe for the discussion, we observe the left eye, there is no to minimal symptoms, stable acuity, regular tomography and small Kmax increase. Maybe for the discussion, keratoconus is well known for the bilateral in most cases. There are unilateral cases, but it's a very, very small prevalence. So does this eye, the left eye, meet the criteria for the formefluste? Would the biomechanical testing will help in this case because we don't have the biomechanical until now? And is this a watch and wait case, or do you think that this is the candidate for early CXL? Maybe that's the question for the discussion. Thank you.
Terima kasih Dr. Joan. Ini kita lanjutkan dulu dengan pembicara ketiga. The third speaker would be Dr. Gairi Kundu. Dr. Gairi Kundu adalah konsultan di bidang kornea dan refractive service di Narayana Netralaya, Bangalore. Please, Dr. Kundu, the floor is yours.
So I think my job is kind of very easy. Thanks a lot for the invite. Surabaya is a beautiful city. I'm yet to go sightseeing. So tomography or topographers, I think have of course undergone a lot of advancements. And what's important for you to understand is you need to have a tool. Finally, why do you need imaging? You're trying to segregate patients, those who are fit for refractive surgery, patients where there is an early weakening, so that you know that these are the patients you aren't, going to do a surgery for. Majority of it is easy with a lot of systems, patients which are completely normal, well, that's easily detectable. Ones which are, advanced keratoconus, I think even clinically you can detect it. But it's the ones which are in between, the ones which kind of don't fit the bit, an early ectasian evolution, biomechanically weak cornea. Can you detect that with, a screening device, a screening tool? And that's where understanding what devices we need come into the fore. So it's always been the deciding factor, but even in cases where sometimes tomographers, don't detect, or preclinically or, preoperatively look normal, but you still see patients coming up like this. So are we really missing something? And that is the question we need to ask ourselves. The trend has been going on in terms of hybrid devices. Nowadays people want multiple functionalities into one, and that is something which we need to understand, that you need to fit in everything inside it, but at the same time retain the functionality. It shouldn't be a compromise, that you fit in aberrations and you don't look at developing or, reducing the efficacy of tomography. So that's where it's important, where though this has been the deciding factor, is standalone topography enough? The question is no, because I'll be taking you through cases as to where you need to integrate not only at tomography, move ahead, look at biomechanics, and also look at epithelium. And that's what it's important, and that's what Pentacam and Oculus has been trying, in their armamentarium, in trying, I think many of you would be aware of the evolution. And if you have time today, I would also be sharing a little bit on the Pentacam OCT towards the end of the day. So what does an AXL wave do? It basically combines, of course, you have tomography. It also gives you an option of looking at the axial length and thereby looking at IOL-PAR calculations. That would be the later part of today's event. And aberrations. Integration of a tomographer with an aberrometry is what Pentacam AXL wave is. It also is useful for cataract surgeries and IOL-PAR calculations. And that's where using a tool like this could help us in, improving our practice, whether it is refractive or whether it's premium cataract practice. So it gives you aberrations. You're looking at corneal aberrations. You're looking at the total eye aberrations. It uses a Hartmann-Shack aberrometer, and when you remove the corneal from the total eye aberrations, it gives you internal aberrations. The understanding or the misunderstanding is internal aberrations are predominantly lenticular. Yes, no doubt, but lenticular aberrations are a part of it. So this also helps us in customizing surgeries, whether it's refractive surgeries. Not only that, it also helps us in looking at outcomes, inadvertent outcomes after refractive surgery, which kind of helps us in customizing as to what treatments we want to do. So, like I spoke about, this is the Hartmann-Shack aberrometer. So these are the main tenets, in how sequentially the AXL wave gives us. You're of course looking at an aberrometry. The retroillumination basically talks about the crystalline lens, the preoperative crystalline lens, and also about the postoperative IOL position. The axial length, I would be coming to that at the later part of today's talk on the IOL-PAR calculations, and of course the tomography. Now the basic aim is of course using or optimizing these devices, and the tenets of how it proceeds with it still remains the same. You have varying devices, they still give you the same information. You're looking at a FOMAP, you're looking at thickness, you're looking at elevation. In Pentacam we do some looking at, there's a reference plane which is known as a best fit sphere, where we are able to look at the anterior elevation and posterior elevation. And finally, an accuracy of a device is more related to how accurately it images posterior elevation, and that is something which you need to remember. And that is what distinguishes many of these devices in how we are able to screen out cases, screen out keratoconus, screen out form for keratoconus, and that's what is important here. So you, of course, are interpreting images the same way. I don't want to go into how you actually interpret this. You're of course looking at the curvature. Early keratoconus, moderate. This is an advanced keratoconus. Like I said, devices are able to detect keratoconus clinically, but it's scenarios where it's somewhere in between is where these devices play. Cutoffs, when you're looking at posterior elevation. If you're looking at the cutoff, if it's above 20 on the posterior elevation map, it is clinching for keratoconus. Anywhere between 17 to 20 is suspicious, and less than 17 is normal in the posterior. Similarly, anywhere above 15 on the anterior elevation map is considered to be keratoconus. So elevation maps is something which has helped. You're of course looking at changes on the curvature, but you're also correlating that with changes on the anterior elevation and the posterior elevation, and that is something very important for us when we're trying to diagnose keratoconus. Belen has of course done a fantastic job. Everybody loves indices. Dr. Brendan spoke about, well, I need a cutoff, but it's also imperative that you know individual indices. Bad D, there has come out with a cutoff of 2.6 being, keratoconus, no doubt. But there are individual factors. If there's something known as DF, DB, DT, DA, and DP. So 2 of these are basically curvature driven, and the last 3 are basically driven from the thickness. So anything which changes these parameters, they basically build a regression analysis, looked at a normative database, looked at a patient with keratoconus, and looked at patients in between, and something like an AI regression analysis, and they came up with individual cutoffs. So why is this important is, though D value is 2.6 being keratoconus, cases where you are looking at thickness being slightly on the lower side can sometimes drive D value to be somewhere in between. Okay, so if you see a 490 micron cornea, it need not be an abnormal cornea, but that sometimes can drive the D value to be somewhere in the yellow. So you need to know individual parameters as well. So let's take a case. This is a patient coming in for refractive surgery. You do a detailed evaluation. You see no significant posterior elevation, but what you see interestingly is there is some amount of inferior steepening. And if we go in and dwell towards looking at the biomechanical parameters, I think I don't want to explain. Dr. Brendan's already done a wonderful job of that. You see the CBI being normal, but you see the bad D being somewhere in between. Now, what do we do in such cases? And if you see there is an inferior steepening in the FOMAP, this is where sometimes other tools such as epithelial mapping, and that Oculus has come out with the Pentacam OCT, which I will be speaking on, is you see an area of focal epithelial hyperplasia, and that kind of correlates with the area where it is steepening. So that actually sometimes is driving the bad D to be somewhere in middle, but if you see the CBI, that correlates very well. It's in fact a normal cornea, and therefore what I'm trying to drive in is, don't base your judgment only on one tool. It is useful and imperative to have multiple devices as well. And biomechanics here in the case is a normal cornea. It is in fact, the epithelium which was masquerading as a focal inferior steepening. So therefore, interpret your scans with caution. The second important thing is, all thin corneas are not weak. Okay, this is a case which is a 418 micron cornea. This is still normal. And this is a thick cornea, which is 600 micron cornea. So we have been doing imaging on something known as collagen imaging, which is polarization sensitive OCT. It's finally the strength, which is inherent collagen structure, which gives the strength to the cornea. So don't base your judgment only based on the thickness. The patient who had a 600 micron cornea, in fact, was a patient who had an early Fuchs. And that's what it showed up as a thick cornea with if you see the exclusion maps, there is a posterior float, you see a difference. So this message is to drive that interpret your scans. Don't base your judgment only on thickness. It's not that a thin cornea is a weak cornea. It's not a thick cornea is a better cornea. So therefore, you need to have access to understanding the actual corneal strength, and that's where it's, it's very important. So a series of cases in where you see bad D sometimes being driven to somewhere in between. That could be as a consequence of it being thin, or changes in the epithelium masquerading as changes on the curvature. But again, CBI is many of the times a clincher in these cases where, it's giving you the actual strength and giving you an information as to whether you actually proceed with surgery or not. Skewing, I don't want to go into the details on this, the symmetric and the asymmetric brow tie. Form first keratoconus, you see early subtle changes. Remember, posterior elevation cutoffs is something very, very important, and that is something which can help you when you're looking at this. So I don't want to go into the ABCD display. Yeah. After this, you want me to stop? That's okay, no problem. You want me to stop now? I'll stop for the coffee break and come back then.
Because we're going to do the panel talk, and then because this is actually supposed to be this.
No, this is the talk now. Yeah. Yeah, this case is ahead. So this is about the ABCD display, and there is an interesting option of something known as the corneal densitometry as well, where we are able to quantify, the corneal haze. That's more related to the, the anterior part of the cornea. So this is useful in also your post-operative outcomes, whether it's post-C3R, post, PRKs. And it's important to understand that this has a very important role in correlating with repeatability of instruments. So therefore, you shouldn't be really imaging patients immediately post cross-linking and post PRK. Densitometry has an important role in those scenarios. I know Dr. Brennan doesn't, look at progression per se in the comparative maps, but just for completion, you need to look at points of steepening, which is preferably 3 points of steepening in the center 3 millimeter zone, and they should be a pachymetry drop as well. But having said that, even we have shifted completely to ABCD progression display in kind of looking at quantifying, whether the patient is actually progressing or not. But just for completion, I wanted to, show some examples on, patients are stable on the comparative display. It is also worthwhile to integrate this with the ABCD progression display, the same as well. Now, what I wanted to finish up, this is something known as asymmetry indices. We as refractive surgeons do not go beyond the FOMAP and BAD-D, and it would be prudent to actually go into other indices which the Pentacam gives, which is known as asymmetry indices. Finally, even earlier than changes you see on the curvature map would be changes which you see in asymmetry, whether it's an inferior superior asymmetry. And Pentacam gives you a lot of indices which are based on this, something known as index of surface variance, the index of vertical asymmetry, index of height decentration. What they tell us is that any subtle change, whether it's inferior, superior, is detected earlier than what is detected on the curvature map, and asymmetry indices are something which is worthwhile when you're looking at patients who are suspected to have keratoconus. Now, posterior elevation, I spoke about posterior elevation being an important aspect, but what I also wanted to talk about is cases where you see patients who are coming in with steeper corneas, with some amount of posterior elevation, and what sometimes we miss is something known as the white to white. So in our population, sometimes we have cases where there is a small white to white. It is always worthwhile to look at white to white leading to a pseudo steepening and interpreting that with a pinch of salt, and then basing your judgment as to whether you want to go ahead with surgery or not. So, there is an interplay of white to white with corneal parameters. This is something we have also published. Many of the groups have published on how white to white play an important role in interpreting scans. And therefore, a lower white to white may correlate with an increased posterior elevation and a pseudo steepening. So therefore, you see cases which are steep, some amount of posterior elevation. Do look at the the white to white in such scenarios. So you choose an appropriate procedure. You can use the AXL wave in looking at aberrations. I spoke about it giving you total corneal aberrations it gives you the total eye aberrations and also the internal aberrations. How is that helpful to us as refractive surgeons is that you can actually base and customize as to what type of surgery you do based on the match or the mismatch between the corneal aberrations or the patient acceptance and the patient astigmatism. So in cases where there is a match, a topoguided treatment could be done. Cases where it's predominantly, where the pentacam measured cylinder tends to be higher, you could again do a topoguided treatment. But it's in cases where the patient acceptance is sometimes much higher, and that could be a role of lenticular aberrations being in the, in the picture. Then what is measured on the pentacam is where in these cases we could do optimized treatments or wafer guided treatments. So in this, we are basically trying to summarize as to how you use pentacam to not only diagnose keratoconus, that is something which you can do, of course, but look at subtle pictures in terms of changes in the curvature, correlate that with elevation. Epithelium would, of course, be a useful tool. Biomechanics as a screening tool is very important. I'll be doing that in the subsequent talks. And aberrations, how we play around with aberrations and choose what type of surgery we are doing. That is also something which is very important. So I thank you for your patient listening. Yeah.
Thank you, Dr. Khairi Kundu, for your interesting and insightful presentation. Kita memasuki sesi berikutnya, sesi diskusi. Sebelumnya saya mengundang kepada para panelis, Dr. Dini, Dr. Ucok, dan Dr. Emi untuk naik ke atas panggung. Kami persilahkan. Dr. Dini dan Dr. Emi, silakan dok. Baik, kita langsung ke sesi diskusi. Silakan kepada para audiens jika ada pertanyaan untuk para pembicara. Kami persilahkan. Silakan dok, monggo. Atau dari panelis mungkin menanggapi.
Selamat pagi teman-teman sekalian. Saya mau menanggapi mengenai pertanyaannya Dr. Nina tadi tentang apa memang perlu kita segera melakukan kolagen cross-linking ya, Dr. Nina ya. Itu tergantung case-nya Dr. Nina. Dan pada kasusnya Dr. Cronin, nah kasusnya dia itu masih mild keratokonus. Dan itu baru suspek aja di topografinya mungkin kan. Di literatur Ricardo Scotto tahun 2021 dia pernah mereport kasus corneal ectasia dengan hanya follow up 1 tahun menganjurkan air rubbing si anak ini di stop, terjadi perubahan dari topografi. Jadi sebenarnya kita bisa wait and see dulu kalau misalnya kita masih suspected ya. Terus mengenai topoguided collagen cross-linking, tujuan awalnya sebenarnya menyeimbangkan kurvatur yang irregular itu dengan laser dan dikombinasi dengan penguatan cross-linkingnya. Harapannya corrected visionnya dia bisa kita capai. Dan kedua, kalau kita mau fitting dengan RGP itu akan lebih mudah. Jadi harapan untuk visual rehabilitationnya jadi lebih memungkinkan. Tapi itu hanya optional ya. Kalau misalnya contoh kasus-kasus dengan two step atau apa di nggak imbang kanan kirinya, superior inferiornya bisa kita bikin landai dan seimbang. dengan laser itu. Nah, jadi kita emang harus pintar-pintar lah milih kasus, gimana treatmentnya, supaya apalagi misalnya di klinik kita hanya ada RGP, nggak ada scleral lens, karena masing-masing type itu punya, terutama RGP ya, RGP itu di atas 5 astigmatism, 5 atau 6 itu udah mulai timbul risk untuk corneal scar. Makanya beberapa literatur menganjurkan untuk scleral lens karena efektif dalam rehabilitasi vision maupun comfortable dari pasiennya. Terima kasih. Itu aja Dokter Rina.
Terima kasih Dokter Ucok. Mungkin dari panelis lain atau mungkin menanggapi presentasi kasus dari Dokter Joan tadi ada beberapa pertanyaan ya. Mungkin bisa ditayangkan presentasi Dokter Joan yang tentang kasus. Panelis boleh. Silakan Dok. Dokter Dini nih mic-nya.
Izin boleh bertanya ya panelis?
Silakan Dok.
Untuk Dokter Yohan. Nah, untuk Dokter Yohan pengalamannya saat ketemu keratokonus ya, kemudian pilihannya scleral lens atau RGP itu bagaimana Dokter Yohan? Mungkin bisa di-share buat teman-teman di sini. Terima kasih.
Terima kasih Dok. Jadi kalau untuk di tempat kami sendiri, karena memang ketersediaan RGP-nya hanya memang spherical RGP. Jadi untuk case-case di mana memang astigmatnya, kalau di saya perhatiin kalau dia terlalu skewing atau misalnya astigmatnya terlalu tinggi di atas 4, itu memang RGP nggak bisa nge-cover. Tapi karena kita sudah ada corneoscleral lens, kayak yang pada pasien ini, dia dengan astigmat -5 kita fit dengan corneoscleral lens itu bisa reguler korneanya, jadi makanya visusnya bisa almost 1:0 gitu Dok. Jadi sebenarnya kalau untuk semua case apakah harus skleral atau corneoscleral, kalau untuk pengalaman saya pribadi sih Dok nggak semuanya harus. Jadi ada beberapa case yang memang dia kalau nggak terlalu skewing atau misalnya astigmatnya nggak terlalu tinggi itu dengan RGP juga bagus. Dan memang benar tadi kata Dokter Ucok juga, jadi salah satu kekurangan dari RGP ini adalah kalau dia touch dengan kornea. Jadi itu akan bikin another mechanical trauma yang bikin makin parah nanti keratokonusnya gitu. Jadi memang kita selalu dari studi mengenai RGP untuk keratokonus kita pilih yang memang lebih steeper daripada korneanya. Jadi kita menghindari touch dari si korneanya ke lensa. Mungkin itu Dok dari saya. Terima kasih Dok.
Terima kasih Dokter Joan. Dokter Emi monggo.
Oke, terima kasih Dokter. Kalau tadi pertanyaan ke Dokter Joan, saya mungkin nanya ke audiens dulu ya. Sebenarnya ini mungkin banyak yang dokter-dokter dari bagian bedah refraksi, surgical maupun non-surgical, saya lihat. Boleh saya tanya, dari sekian banyak dokter di sini yang sudah mempunyai modalitas topografi kornea, berapa banyak ya Dok? Topografi aja, topografi. Oke, topografi dan tomografi. Kayaknya topografi lebih banyak ya. Kemudian yang punya topografi, tomografi dan juga ada biomekanik kornea, korvis lah. Oh, cuma Dokter Mayapada nih. Oh ya, Mayapada. Oke. Jadi kalau selama ini kan kita memang di Indonesia rata-rata belajarnya kan pasti berpikir kornea adalah kornea topografi dulu. Kemudian tomografi, kemudian lately kita belajar biomekanik kornea gitu. Jadi kalau dari presentasi dari from Dr. Gary Kundo and Brendan Cronin, it is so important to we know about biomechanical cornea. How about your suggestion for us? It is mandatory we have to concern about biomechanic cornea. Let's say we have to use corvis to all patient to going refractive surgery, this LASIK or SMILE like that.
how big this suggestion for us?
It's a good question. Smile or lenticule, you know, there's different versions, Smile and Clear and Silk. Everyone thought that patients would be, that Smile would be better for biomechanics than LASIK. But that's not really the case. Lenticule extraction takes more tissue. You'd think it would be better. You'd think Smile would be better for weak corneas, but it's not. So your cut-offs are the same for Smile and LASIK, basically. The issue with Smile is it takes more tissue than LASIK for the same refraction. And the assumption with it was you could, because you were leaving that cap of anterior tissue, that that was going to contribute more to the biomechanics. But if you have to top up a patient who has Smile, you have to cut that cap off and do LASIK. So I guess the answer of how to biomechanics factor in that they can rule a patient in for Smile or LASIK, but really the distinction between whether you do Smile or LASIK isn't based on topography or biomechanics typically. It's based on dry eye and whether their cornea is irregular. So you can't do a topography guided Smile treatment. So all my LASIK are, and Smile or lenticules, not as good at high astigmatism and things. So yeah, so biomechanics, they rule them both in or rule them both out, but the decision as to Smile or LASIK is based on other factors. Yeah.
How about you, Dr. Gary?
So corneal strength, like Dr. Brendan highlighted, is sometimes predates changes in your tomography, right? So I'm not saying that you can, you need to have both, but I will be speaking about this in the next session on how, the interplay between tomography and biomechanics. What do you do in such scenarios? 70-75% of the times, your tomography is normal, your biomechanics is also normal. But it's about the 25% of the times where there is a mismatch, it being normal, but your biomechanics is abnormal. What happens in those scenarios? The ones which fall in between. And that is, I think, the decision making we need to do. Majority don't have problems because it's, the patients fall in the 70% where, you're looking at any of the imaging tools they have and it's normal. But biomechanics is not to reject patients. In fact, that's going to optimize your practice and convert more patients is what we normally tell people. It's not a way to reject patients, but in fact, those patients which might have been rejected because of certain changes in the tomography might be accepted back, and might in fact have a suitable surgery because of biomechanics being present. So that is what is the key. It's important to remember, yeah.
Okay, thank you. Ada lagi?
Silakan Dokter Dini. Oh sebentar, Dokter Dini, maaf Dokter Tigor dari tadi mau tanya. Silakan Dokter.
Terima kasih Dokter ya. A quick question to Dr. Cronin actually. You mentioned about how important the Corvis might help us in doing the pre-LASIK examinations before doing the procedure. But in my hospital, I only have Pentacam. Do you have any suggestions to us who only have the Pentacam but we still don't have the Corvis? Because you mentioned about the possibility of missing out things that might increase the possibility of the post-procedure ectasia. Thank you, Doctor.
I still think the Pentacam is a fantastic screening tool for refractive surgery. It's fantastic. It's the gold standard around the world. The Corvis just adds to it, so it makes it the double gold standard. So with a Pentacam alone, as we're saying, Corvis will often let you do laser on patients that the topography would have said no. So yeah, if you just follow the indices on the Pentacam, you're in really safe territory. And of course, there are calculators, so you work out your cap thickness and how much you're going to ablate. to work out how safe you are for LASIK. And we still do that in all of our patients in clinic. We plug them into a little calculator, working out the cap thickness and the residual stromal bed using those indices. So using that alone with Pentacam is fantastic. It's still a very good way of screening for the risk of post-LASIK ectasia. So Pentacam's excellent, but you can add a bit to it if you have a corvus. Yeah.
Ada mungkin dari panelis ada tanggapan, dokter? Okay. Thank you, Dr. Cronin.
I want to ask to Dr. Cronin and Dr. Kairikundo, how about the biomechanic cornea in children? Because we found keratoconic in children. Is it the same with the adult patient, or? And also, how about your experience with the riboflavin oral?
So, in terms of how biomechanics has a role in pediatrics and adults is still the same. At what age is your question on how it I mean, is a pediatric biomechanics same as an adult? No. But whether the role of biomechanics in your pediatric progression versus your adult progression, the role is still the same. Again, just to highlight certain points, people who are asking about keratoconus progression, we are finally treating the patient and not the image or the scan, right? So always remember that you have these tools, but also look at additional risk factors which Dr. Brendan spoke about, patient being young, active allergy, we're looking at eye rubbing. These are also demographic factors which have to be factored in before we decide as to whether we're going to cross-link or not. So imaging is one of it, and that's a very important aspect of it. But finally, we're not going to be doing cross-linking on the image. We're going to be doing cross-linking on the patient. And therefore, the additional risk factors is something which is very important. In terms of, we have done studies comparing biomechanical changes in pediatrics versus adult. There is some controversy as to at what age a pediatric cornea behaves like an adult cornea. Some say, collagen remodeling continues till about 13 or 14. But like I said, a patient who has allergy and rubs his or her eyes but does not have keratoconus will still have a different biomechanical picture than a patient of the same group who's normal without eye rubbing versus, of course, a patient who has keratoconus and will, of course, have changes in the biomechanics. I hope I was clear, right? So it's very difficult to put it into one that, well, he's 13, he has this biomechanics and this is the cutoff. No, it's difficult to say that. But it's not a single time diagnosis. You image the patient, you do a tomography, you do a biomechanics, and you follow them up. That's where I think progression and how it pans out over 6 months or years is where these imaging tools have a better, role in, is what I would say. Yeah.
Yeah, I agree with all of that. And the other thing in cross-linking, I had to fly from Brisbane to Singapore and then Singapore to Surabaya, and the flight from Singapore to Surabaya was about 2 hours and 20 minutes. I will have patients fly 2 hours and 20 minutes to see me. So you have to factor in for keratoconus distance and how hard is it for them to get back to see you, and the parents. And some parents, if they have a family history of keratoconus, they're not leaving your room if you don't offer cross-linking. They say, no, I'm not here really for your opinion. I am here for you to cross-link my child. They have keratoconus. They weren't born with it. I have a corneal transplant. You're cross-linking my son or daughter. And that's important. So there's so many things. But younger kids, they're not born. If they get keratoconus when they're young, it's aggressive. There's a very good argument to diagnose, to treat in younger children keratoconus on diagnosis.
Baik, mungkin satu pertanyaan lagi ya karena waktu terbatas, silakan dok.
Does the corneal biomechanics impacts or change your parameter settings when you do a lenticular extraction or LASIK? if it's yes, is there any protocol that we can use to adjust our parameter settings like cap thickness or etc. when we based on the biomechanics? Thank you.
Yeah, so one is of course your preoperative screening, whether they are fit for surgery or not. That's a very good question because what we have seen is when you look at, anyway that's part of the next session, but when you look at CBI, there is one parameter which is known as SPA1, stiffness parameter at the first applanation, okay? What we have seen, and we also ran an AI model, is in specifically lenticule surgeries, corneas which have, they are normal no doubt, but some corneas are excessively stiff. The SPA1 tends to be very, very high. In those cases, what we found, there was a correlation between difficult dissection in the cases which were very, very stiff. And therefore, that immediate post-operative outcome on day one might have been maybe a notch lower. But having said that, in long-term outcomes, in, you know, you're looking at a month, 3 months, and 6 months, it does not, you know, your biomechanics, you know, a highly stiff cornea will not correlate to a, poor outcomes in the long-term one. Very stiff corneas, we can alter certain parameters in terms of energy while we are doing the dissection, so as to enable a more smoother dissection. But this is still work in progress. I mean, it's still something we're trying to titrate, whether there's a correlation between SPA1 and dissection, whether energy alterations can lead to a easier surgery. But having said that, 99% of the times there is no problem. It's only that 1 or 2% of the times where we'll have to titrate or alter our energy settings, especially for lenticule surgeries is what we have seen, because it involves dissection. In terms of LASIK, personally, no. I mean, it is a biomechanically strong cornea. You generally, invariably will not have any issues while you're doing a flap-based procedure, is what we've seen, yeah.
Okay, thank you.
Oke, terima kasih. Jadi dok, mungkin satu lagi terakhir ya, silakan dok.
Thank you, doctor. My name is Hendra from IQ Makassar. So our center is relatively new, and our hospital is eager to invest more in the diagnostic tools. But from doctor's point of view, having more tools is very important because it increases our safety and also our patient safety. But from the management point of view, we need to give them number, sadly. So the question is, if we have this borderline case, because Corvus is very important for a borderline case or something that a suspicious case, how many from your clinical practice can we convert from this suspicious case to legally can be done LASIK or SMILE? For example, we have done hundreds of eyes during these past months, and then we see, for my case, I have only get around 3 borderline case, and my colleagues maybe have 1. So the percentage is basically for the borderline case is very small. So from your point of view, what is the number of conversion if we buy Corvus and then we increase of safety? But how can we ask for the management to invest in this wonderful machine? That's number 1. And then vice versa for this question, what if our pentacam pick that everything is good for this patient, but Corvus find other thing? It will be counterproductive for the management, but it's safety for the people and for us, a doctor. So what do you think about these 2 questions? Thank you.
So, it's a good question on how there's always the management saying otherwise, but I'll take your last aspect of what you spoke about, your tomography being completely normal and your biomechanics is completely abnormal. That is extremely rare. With just, like I said, a good imaging tool which images your posterior cornea, posterior elevation, what we have shown is a Scheimpflug based device such as a pentacam, the pentacam HR, and now of course the pentacam AXL wave, can cater to, I think, almost 80 to 90% of your refractive practice, okay? It's just that the images which you see in the pentacam sometimes might not be enough in terms of some people base their judgment only looking at the bad D, some base their judgment only looking at the axial curvature or the thickness, which might not be enough. So you need to look at the imaging or the tomographer in total, where you're correlating. I spoke about a change in the inferior steepening, which was actually as a consequence of epithelium. But if you noticed in those cases, the anterior elevation and the posterior elevation was normal. So I know that there is some steepening, but I know the anterior elevation and the posterior elevation is still normal. And I also look at D not as a whole, but those individual parameters, you know, your DF, your DB, your DP, specifically something known as DT, which is the displacement of the thinnest point. Okay. Now, these individual parameters also gives me an idea as to whether this cornea is normal or whether this cornea is an ectasia in evolution. With just the FOMAP and BAD-D, I can still decide on 90% of my patients, right? The additional parameters which I spoke about is something known as a topometric KC staging. Okay, those asymmetry parameters tend to be a little more sensitive than BAD-D. But having said that, that is present on all of the models of Pentacam, AXL Wave, HR. So if you look at it in total, to start off with, you will need a Scheimpflug device. There's no doubt about it. You would need a device which is repeatable not only in normals, in pediatrics, but also repeatable in keratoconus and post-refractive eyes, which has again been consistently shown by multiple groups, including us. And this should be enough for you to start off with. What we are trying to highlight is those 5 to 10% of patients where there could be a mismatch. We will be discussing that, is where this adds to your existing one. So you, of course, are investing on a tool which is, you know, a Scheimpflug based device. What Pentacam is coming out with is additions or hybrid devices. You know, I spoke about aberrations being added to it. I spoke about IOL power calculations and, you know, axial length, customizing IOL power calculations in that model. So having this is in fact more than enough. Okay, it's just that cases where, you know, if you have a load where, you know, there are patients who don't fit the bit, it is to optimize your practice so that you increase is where you can add on to biomechanics, and that is what is useful. So what would be a better strategy with your management is to go ahead with first talking about a device like AXL Wave, and then after some point putting in regarding Corvus. Don't go asking about multiple devices at one go. That is a strategy which even we do. You know, if I need to go and speak to my boss regarding some tools, you need to justify as to why you have that, how is it going to optimize your practice. Okay, people think that more diagnostics, more screening criteria, and I'm excluding patients. That's never the case. Your practice is actually going to increase with these kind of screening tools. Like I said, but a very important thing which I spoke about is that 90% of your practice, you have an AXL Wave. It's going to help you in your cataract and your premium, premium cataract as well as refractive. And I think that should be enough to start off with and add on to Corvus as you, build your practice. That's what I would say.
I'd probably say patients love the safety of extra scans. They notice it. They often go to multiple clinics and they'll say, I didn't have this at the last one for my LASIK consultation. And so they love the Corvus. Unhappy patients with ectasia are terrible for your business. They cost you a lot of money. They tell a lot of people. The simple summary is, so what he's saying is if you're really, really smart, you can almost pick up every ectasia based on the Pentacam. And so he doesn't need a Corvus. I'm a little bit dumb. And so if you're not really smart, the Corvus makes refractive surgery safe for people who are a little bit stupid. And you can just go TBI. So I agree. That's the summary. I'm not smart enough to look at all those indices. It makes it idiot-proof. That's the beauty of it. And I think you get more patients from it.
I'm sure in Indonesia and in India, we need to kind of justify why we're investing in a device is what he's trying to say. I think it's easier maybe in Australia, but here, why do we need a device? And can it have multiple functionalities? And that's where I think hybrid devices, where it does not compromise on your core function. You have a lot of hybrid devices coming in, which don't give you good information on your posterior float or your posterior elevation. But what Pentacam, AXL Wave, and of course OCT has done is you're fitting in a lot of things, but you're preserving the core functionality and the accuracy of each one of them, each one of those functionalities. We looked at AXL Wave aberrations and compared that with eye trace, and we found a very good agreement. Because eye trace was earlier the gold standard, it's still the gold standard in looking at aberrations. But would you only invest in an eye trace, or would you invest in a device which also measures aberrations like the eye trace, but also gives you IL-PAR calculations, but also gives you a good Scheimpflug, you're looking at your good screening indices for your refractive surgery. So that's where I think as we go ahead, they would be, and I'm sure Richard would acknowledge that, is they are trying to build in multiple things and multiple tools into one device, and that's where the future is. Okay. Right now we cannot integrate biomechanics with tomography as a one device, but I think that is something which companies like Oculus would be looking at. Yes.
Dengan demikian kita akhiri dulu sesi.
Just one real fast.
Sorry.
Sorry. Also, though, I think with the question there, are you losing any patients? Are you losing that refractive patients? Are they gone?
No.
So you don't lose any patients by adding in the Corvus?
That's what I think I told you. You're not going to exclude patients. You're actually going to increase the number of patients. You convert for surgery, and that's what is important. Yeah.
Baik. Baik, kita akhiri dulu sesi 1. Thank you to all the speaker and panelists for the knowledge you share with us. Big applause for the speaker. Baik, para panelis bisa meninggalkan tempat. Also the speaker. Saya serahkan kembali kepada panitia. Terima kasih.
Terima kasih Dokter Ria. Boleh kita berikan tepuk tangan sekali lagi para dokter sekalian. Wow, luar biasa. Masih semangat ya para dokter di sini. Kita masih panjang sekali agendanya, tapi yang pasti untuk sedikit menyegarkan Anda semua, ini coffee break juga telah dihidangkan di meja Anda masing-masing, dan tentunya sambil menikmati coffee break ini jangan lupa untuk Bapak Ibu dokter ya, selain agenda seminar kita di ballroom hari ini, nanti malam akan ada gala dinner di mana boleh sedikit loosen up sedikit gitu ya. Nanti mungkin mau belajar ini pantun sama Dokter Nurdin ya. Kuliah singkat bikin pantun ala Surabaya gitu ya Dok. Baik, jadi sekali lagi nanti untuk gala dinernya ada di 360 Restaurant, itu ada di lantai 23 dan akan kita mulai pukul 18.30. Dan sekali lagi untuk Anda bisa mengikuti, nanti boleh dinikmati hidangan spesial ini, refresh gitu ya. Karena sesaat lagi kita juga akan menyaksikan, kita akan melanjutkan dengan industrial presentation. Oke, jadi silahkan sambil Anda menikmati coffee breaknya, boleh saya mohon untuk bisa kembali ke tempat duduk masing-masing ya para dokter sekalian, karena kita akan sama-sama mendengarkan industrial presentation yang akan disampaikan oleh PT Optik Persada Nusantara. Sekali lagi, ini memang saya percaya para dokter di sini ada yang lama nggak jumpa gitu ya, jadi sekalinya ada kesempatan sedikit reuni di belakang sana. Luar biasa sekali. It's okay. Tapi yang pasti Bapak Ibu dokter yang di belakang boleh diminta sedikit perhatiannya, karena kita akan segera sama-sama menyaksikan industrial presentation. Baik, kalau begitu saya persilahkan dari PT Optik Persada Nusantara untuk memulai. Silakan.
Assalamualaikum warahmatullahi wabarakatuh. Ya. Oke, terima kasih. Oke. Rekan-rekan semuanya, para dokter, para hadirin semua, izinkan tadi diawali dengan pantun, saya juga ingin memberikan sebuah pantun. Oke. Pergi ke pasar beli semangka. Kaget, ketemu kucing naik sepeda.
Cakep.
Halo para dokter semua, perkenalkan saya Alam dari PT Optik Persada Nusantara.
Cakep.
Oke. Tambahin lagi ya, satu lagi. Visit ke dokter, bawa donat 5. Satu dimakan, sisanya lupa. Saya hadir bukan sekedar jumpa, tapi bawa alat yang bikin diagnosa dokter makin sempurna. Selamat pagi para hadirin semua, saya bersama rekan-rekan hadir di sini untuk membahas solusi alat kesehatan mata kami dirancang agar dapat terintegrasi secara praktis dengan klinik atau rumah sakit semuanya. Meningkatkan ketepatan diagnostik serta mengoptimalkan hasil bagi pasien. Didirikan pada 15 Februari 2016, PT Optik Persada Nusantara melayani berbagai klien seperti rumah sakit, klinik mata, dokter mata, dan optik, baik retail maupun independen di seluruh Indonesia. Dikenal sebagai penyedia produk dan layanan berkualitas di bidang ini. Di Optik Persada kami memiliki 4-star service, 4-star service yaitu sales dan marketing, after sales service, clinical training dan education, consultative sales and solution. We don't just sell devices, we sell the ability to see the world more clearly. Every innovation of ours is an investment in a brighter future of sight. Oke, this is our specialist. Berikut adalah tim spesialis kami, ada Pak Dedi dan saya Alam. Lalu di belakang ada Hilman, ada Pak Isa dan Pak Chandra. Oke. Oke. Instalasi produk kami diantaranya sudah ada di RSUP Komodo Labuan Bajo, di RSUP Sitanala, RSUD Balaraja, Rumah Sakit Unpad, Klinik BSC Bandung, Rumah Sakit Mata Bali Mandara, IMC Hospital, dan Smack Group, serta rumah sakit lain. Oke. Berikut adalah prinsipal dari produk yang saat ini menjadi bagian dari portofolio kami. Produk unggulan kami yaitu adalah dari MediWorks slit lamp. Slit lamp kami memiliki 3-in-1 function, yaitu slit lamp standar, tapi dia memiliki juga fitur meibomin assessment dan dry eye analysis assessment. Kelebihan dari slit lamp kami yaitu dia memiliki HD optical system dengan optical resolution hingga 200 line pair per millimeter. Oke. Untuk portable products kami dari MediWorks ini, kita punya FC161, FC162, 161 yaitu handheld photo fundus, lalu juga FC162 automatic photo fundus, V100 yaitu vision screener, C901 vision chart, dan S150 slit lamp portable. Seperti kita bisa lihat, slit lamp portable kita bisa digunakan di pasien-pasien untuk anak atau mungkin pasien ICU ya. Oke. Ini adalah salah satu produk unggulan kami yang baru launching di bulan-bulan terakhir ini, yaitu surgical microscope. Para dokter bisa lihat di bagian belakang booth kami. mikroskop kami. Dia memiliki motorized zoom system dengan desain yang very smooth, terus juga memiliki independent assistant microscope. Dan yang paling penting itu red reflex itu lebih baik. Para dokter harus coba langsung nih kalau untuk mikroskop dan slit lamp, karena feel-nya pasti beda. Sorry. Oke. Salah satu produk kami juga dari LKC Technology yaitu ERG VIP testing. Dia bisa untuk diabetic retinopathy, glaukoma, dan pediatrics. Lalu yang terbaru kita memiliki Intellite Dream OCT all-in-one dengan fitur retinal OCT dan speed sampai 400.000 scans per line. Ini adalah produk prinsipal kami dari Forus, yaitu ada Trinetra Aberro, Trinetra Neo, dan Trinetra Neo HD FA. Dan yang terakhir, ini Olize Visual VRP, yaitu untuk perimetri tapi menggunakan VR. Yang terbaru kita memiliki prinsipal dari Optik, yaitu menggunakan alat FC162 sini. Dia untuk assessment glaukoma, diabetic retinopathy, dan AMD, dan juga untuk kardiovaskular. Jadi untuk meriksa pasien menggunakan gambar atau citra dari retina, seperti itu. Saat ini menggunakan AI dan sudah dicoba juga banyak rumah sakit yang cukup tertarik dengan ini. Oke. Ini quote dari saya, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Because at the heart of every tool, every diagnosis and every treatment, we're not just helping eyes to see, but helping people to feel seen. Demikian presentasi dari saya. Terima kasih.
Terima kasih Pak Alam. Nanti mungkin bisa duet dengan Dokter Nurdin ini, pantunan gitu ya.
Boleh dokter.
Luar biasa. Terima kasih sekali lagi. Boleh kita berikan tepuk tangan untuk Pak Alam dari PT Optik Persada Nusantara untuk industrial presentation ya. Baik, para dokter.